Hello, everyone. I'm Dr. Jennifer Hibbard in Toronto, and I'm here with Dr. Colleen Aldous in South Africa, who is a healthcare scientist, and she's going to tell us about the errors in research of ivermectin. Please tell us about it.
Hi, Jennifer. Yes, error decision is made based on the kind of evidence that you have. So you have a type 1 error and a type 2 error, or the synonym would be an alpha error or a beta error. The type 1 error would mean that you look at the evidence and you would decide to go with the evidence even though the evidence is wrong. A type 2 error would be you withhold the evidence, you withhold some sort of decision because you don't know that the evidence is right and the evidence proves to be right later. So this has happened with ivermectin worldwide. The majority of clinical scientists have made a type 2 error in their decisions. So they have not looked at the totality of evidence, and they have looked only at double-blinded randomized control trials or randomized control trials. And many of them keep saying that they are waiting for that one elusive, large randomized control trial because before they have absolute proof that ivermectin works. So in their minds, they're withholding ivermectin because of some spurious side effects that could have a huge impact on the population. And given that ivermectin has had such a long history in human use and has such a wide safety profile, that is verging on an ethical issue. Many other scientists have looked at the totality of evidence, have looked at where the evidence has come from, the rationale for studies, have looked at the meta-analyses and have studied the meta-analyses themselves for bias, are going with a type 1 error, which means that even if it's proven down the line that ivermectin is ineffective in treating COVID, it's safe to roll it out now and save lives. It's a cheap drug. It's not going to cost a lot to get to developing world countries, poorer countries, and it's got such a wide safety profile. The side effects are minimal, they are transient, and according to those people making a type 1 decision, we should roll out ivermectin. And there has been so much evidence that the likelihood of it being shown later not to be effective in the treatment of ivermectin is very slim. So the world has now got two kinds of views on the ethics of ivermectin. And the one is predominantly from the regulatory bodies like the WHO and country regulatory bodies and many academic institutions that are still insisting on waiting. And then you've got the other people who've looked at the science in depth and have said from a humanitarian point of view, there is no justification in not rolling ivermectin out as soon as possible.
Can you tell us the evolution of ivermectin's use in South Africa over this past year?
Ivermectin has always been used by dermatologists on a Section 21 application, which is from our regulatory body. And in last year, people were using ivermectin, and at the end of the year, it was stopped. Our regulatory body stopped the use of ivermectin. And in the missive that they sent out to the public, they put out some misinformation stating that it could actually cause death. And that is what got me interested in ivermectin. So from December, I became part of a group called the Ivermectin Interest Group, and we challenged that missive in late December, early January, and got them to withdraw it. And by the end of January, we had compassionate use of ivermectin through a Section 21 for anybody and for COVID. It was not registered for use in COVID, but we were allowed to access it. The method of getting the Section 21 at the time was onerous, and patients were not going to get the ivermectin. And so other groups took legal action And in the time that legal action was occurring, another drug became registered in South Africa that contained ivermectin, and that opened up the channels for off-label use. So in South Africa, it is legal for doctors to prescribe ivermectin, and people can use it both for prophylaxis and for treatment. However, our government's National Emergency Medicines List Committee still finds that there is not enough evidence to use ivermectin, and their document is still hampering its use in government hospitals. So although it's legal to use it in South Africa, it's not easy for hospitals to get access to it, and the rollout is still being hampered.
How widespread is the use of ivermectin in the community?
In some communities, it's very widespread, and many people are using veterinary preparations and preparations from the black market. And that was what we were hoping to stop by getting SAHPRA to give us access. And now with the NEMLC, now their document halting the use in many hospitals, we've gone back to that, where people are using veterinary preparations and black market preparations. But there's a lot of people in the community using it, and a lot of doctors in private practice who are using ivermectin for their patients. But on the other hand, sorry.
That's okay, go ahead.
There are many doctors who just refuse to prescribe ivermectin based on the NEMLC recommendations not to use ivermectin.
So tell me your opinion of ivermectin. Do you consider ivermectin the silver bullet?
No, it's not a silver bullet. It's certainly part of an armamentarium of drugs. When you have a look at the meta-analyses that have been carried out, it's got a 62% reduction of mortality. So people can still be on ivermectin and die. It depends on when they get the ivermectin. And for prophylaxis too, it's not 100%. So it would be a silver bullet to me if it was 100% effective. But what it is the most effective drug available at the moment to treat COVID-19 as an antiviral.
Let me ask that again. So what is your opinion of ivermectin?
Ivermectin is a very important drug in the armamentarium of drugs to treat COVID-19. It certainly does reduce the mortality rate enormously, and the Bryant et al. Paper showed that to be 62%. And it has, although it's a low certainty evidence rate of 82% success in prophylaxis. So where there are populations that have not been vaccinated yet, 82% prophylaxis is pretty good going. It's much more than some of the vaccines that are still being rolled out at the moment.
Well, thank you very much, Colleen. This has been very informative, and we want to bring to the world one of the important treatments for COVID-19, which is most effective, as you said, as a preventive and early treatment, but it can be used, I understand, in all stages of COVID to be helpful. Thank you so much. Yeah. That's wonderful. Thank you. Thanks everyone for listening. Jennifer. Thank you. Bye.